So these are my disclosures. I've served as an advisory capacity for FEBRA and CIROS, and the Australasian Leukemia Lymphoma Group has received research funding from FEBRA for our APL trials. The topics that I will cover are summarized here. I'll briefly review APL as a distinct entity, go over the evolution of therapy to what is current practice, emphasizing the Australian experience. I'll briefly mention the phenomenon of extreme hyperleukocytosis at presentation, and then also an update on where we are in Australia with oral arsenic. So the entity of acute promyelocytic leukemia was only recognized in 1957 in this paper from Dr. Hillestad from Norway. He summarized of unusual acute myeloid leukemia, which he described as having a very rapid fatal course, lasting only a few weeks, a white blood cell picture that was predominated by promyelocytes rather than blast cells, and a severe bleeding tendency. He suggested naming this disease acute promyelocytic leukemia, and that name has obviously persisted to the present time. And he described it as the most malignant form of acute leukemia. Now, what makes this entity different from other types of acute myeloid leukemia? Well, there are many things. One of the most obvious is the characteristic morphology. On the right, you see the typical myeloblasts in acute myeloid leukemia, and on the left, the cells that predominate in acute promyelocytic leukemia, hypergranular promyelocytes, often with many Auer rods, and also the variant, the microgranular variant, which typically has a dumbbell or indented nucleus and very few Auer rods and very tiny granules, which are sometimes difficult to appreciate with the light microscope. Immunoflow cytometry also shows these cells have a different immunophenotype usually, although not always, typically negative for CD34 and HLA-DR with expression of more mature myeloid antigens such as CD13, CD33. The other feature which clearly separates this disease from all other hematologic malignancies is the cytogenetics and molecular genetics. So the typical 15-17 translocation shown here between the long arm of chromosome 15 and the long arm of chromosome 17. And at the molecular level, this causes disruption of two genes, the PML gene on 15 and the retinoic acid receptor alpha gene on chromosome 17, resulting in a fusion, PML-RARA fusion on the derivative chromosome 15 and a reciprocal fusion, which is not always expressed on the derivative 17, but it is PML-RARA which is what drives this disease. Now, PML-RARA fusion is found in 9% of cases with acute promyelocytic leukemia. Most of those have the typical translocation, 15-17, which is a sole abnormality in about 2/3, and about a 1/3 have some additional abnormalities. There's a small proportion of cases that have complex translocations, often a 3- or 4-way translocation, but still involving chromosomes 15 and 17. And a small proportion are found to have a normal karyotype, but still express the PML-RARA fusion. So that leaves 1% who don't have PML-RARA, and we now see a number of different fusion partners described in what is otherwise a typical acute promyelocytic leukemia. So for retinoic acid receptor alpha, there are at least 16 partners identified, and my own laboratory identified one of these, the PRKAR1A, for which there are now 3 cases in the literature. But there are also rare reports of retinoic acid receptor beta and increasing numbers of retinoic acid receptor gamma fusions with these partners as listed here. Another feature that predominates this disease, and as described by Dr. Hillestad, is the abnormal or the excessive bleeding problems that these patients typically present with. And the pathophysiology is summarized on this slide. Basically, all the problems stem from the leukemic promyelocytes. They release excessive levels of tissue factor and cancer procoagulant, which drive a thrombotic process and a consumptive coagulopathy with disseminated intravascular coagulation. They also release large amounts of annexin, which drive plasminogen conversion to plasmin and hyperfibrinolysis. Underpinning all of this is thrombocytopenia due to the consumption from DIC and from bone marrow failure. And all of these processes are aggravated by a phenomenon known as etiolosis, or extracellular traps of chromatin released by these leukemic cells. Now, standard chemotherapy aggravates this bleeding problem by killing lots of leukemic cells and releasing lots of these procoagulant and fibrinolytic drivers. But it's also now alleged that there's some evidence that ATRA and arsenic also aggravate the problem by aggravating etiolosis. But despite that, they clearly help the overall coagulopathy by maturing the cells and getting past this stage of tissue factor and annexin release. So typically these patients present with very prominent bleeding, but also occasionally with clotting, and thrombotic strokes is a not infrequent problem. This is the major cause of death, an intracerebral hemorrhage, and these are seen in a significant proportion of patients. This is a patient of mine who presented at day 4 with a homonymous hemianopia due to this large intracerebral bleed into the occipital lobe. Fortunately, he survived this, and 10 years later is still free of leukemia. Now, it's apparent that the white cell count at presentation is the major source of many of the problems we see in acute promyelocytic leukemia. Typically in APL, it's low, with a median white cell count in the range of 2 to 3 in most studies. But we know that high levels of white cell count are also the single best predictor of early death from bleeding and also increased risk of relapse. This is data from a study that pooled 5 different trials. The data was collected by Simon Mantha at Memorial Sloan Kettering, and we contributed from the ALLG, the APML3 and APML4 trials, but also data from CALGB, ECOG, and SWOG. So nearly 1,000 patients here, and looking at what was a predictor of early hemorrhagic death. And the single parameter that came out in multivariate analysis was the high white cell count, typically a white cell count above 20 by 10 to the 9 per litre. And this phenomenon of early death is typified in this slide. This is data from the Australian Leukemia Study Group, which is a study group that preceded the Australasian Leukemia and Lymphoma Group. This is a trial going back to before the days of ATRA. And all patients with AML were treated in the same way, whether they had APL or myelomonocytic leukemia or megakaryoblastic leukemia. They all had just standard 7 and 3 chemotherapy. And this is the APL subgroup. And you can see the dramatic drop in survival in the first 30 days. So an early death rate of 24% in that study. And then a progressive further decrease in survival as patients relapsed over time, with a plateau around about 30% overall survival. Now, this problem of early death is an ongoing problem and remains the major problem for this disease. But the level of early death differs depending on where the data is collected from. So on the left, you can see 2 population-based registry studies, the NCI SEER database and the Swedish population registry, with very high levels of early death, 17 to 29%. In contrast, prospective clinical trials, large clinical trials from Italy, Spain, Australia, and France, showing early death rates of only around 5%. At the other extreme, we have a study from Germany in elderly APL, so patients at higher risk of early death, treated intensively with chemotherapy despite their advanced age. And patients on trial had a high early death rate of 18%, but patients treated with exactly the same protocol but not treated on trial had more than double the early death rate. Almost 1 in every 2 patients died early. So that shows the selection bias that typically is associated with large-scale clinical trials for a variety of reasons. Obviously, there's some selection bias, delay in getting onto the trial, so losing the people who die early. But also these trials are very involved with or invested in aggressive hemostatic support, which is a critical component to prevent early death. So lots of platelet and blood product support to minimize the risk of bleeding. The other problem with high white cell count beyond early death is the risk of relapse. And this study from the GEMEMA and PETHEMA groups early in the days when ATRA first became available, they pooled their data because they had similar protocols, and I'll show a bit more about that later, and identified that the relapse risk, this is not survival, this is relapse-free survival, was specifically separated into 3 different risk groups on the basis of white cell count and platelet count at presentation. And so they identified these 3 groups as shown here. And nowadays, we generally just talk about 2 groups. Low and intermediate are combined as standard risk, and high risk is defined as a white cell count above 10, regardless of the platelet count. And it's on the basis of this type of risk classification that the phenomenon of risk-adapted therapy emerged. Now, another feature that distinguishes APL from other AMLs is it seems particularly sensitive to anthracycline-based chemotherapy, and much less so to cytarabine-based therapy. And as you can see, this is an early study from the GEMEMA group before ATRA was available. They randomized patients to a total of 60 milligrams per square meter of idarubicin in induction versus 48 milligrams together with cytarabine. And there was a clear improvement in event-free survival in the higher dose idarubicin group. And there are other data from the Southwest Oncology group that confirm this benefit from emphasizing or increasing the dose of anthracycline-based chemotherapy. Now, the situation clearly changed when ATRA became available. This all-trans-retinoic acid was discovered by the Shanghai group, and they published this report in 1988, complete remission in 96% of patients. And very importantly, ATRA corrected the bleeding, whereas chemotherapy typically makes the bleeding worse. And they also showed that the remission was achieved not through cytotoxicity, but through differentiation of leukemic cells. And that's shown here beautifully in a study from the French group. This is serial bone marrows prior to treatment, day 30 and day 60. You can see the leukemic promyelocytes, some indented nuclei, our rods, hypergranular promyelocytes. At day 30, we see some form of differentiation going on, but there are still our rods in these differentiated cells. By day 60, we now have very mature-looking neutrophils without obvious our rods, and so there's clearly been a progressive maturation of cells in the bone marrow during ATRA therapy. The main problem, of course, with ATRA is this phenomenon of retinoic acid syndrome, now known as differentiation syndrome, because ATRA is not the only drug that causes this problem. It's a capillary leak type of syndrome characterized by weight gain, peripheral edema, fever, dyspnea, and pulmonary infiltrates, pleural and pericardial effusions, and in severe cases, hypotension, renal failure, and multi-organ failure. It's often associated with hyperleukocytosis, a rise in the white cell count, but that's not actually necessary to say someone has differentiation syndrome. And the treatment is well established as dexamethasone, and chemotherapy to some extent also helps prevent or at least treat retinoic acid syndrome or differentiation syndrome. The issue of whether steroids should be used as prophylaxis remains incompletely resolved. There are no good quality trials, randomized trials showing the benefit of steroids, but increasingly steroids are incorporated as prophylaxis in most protocols these days. So we were left at that time with the conundrum of how do you balance the benefits of chemotherapy in reducing coagulopathy, the benefits of chemotherapy in reducing differentiation syndrome, but aggravating coagulopathy, versus the benefits of ATRA, which reduced coagulopathy, but aggravated differentiation syndrome. And balancing that was an important goal and was addressed primarily by the GEMEMA group with this protocol, what became known as the AIDA protocol, ATRA plus idarubicin combined in induction, a standard ATRA given daily, 45 per square meter until complete remission, and 4 doses of idarubicin, 12 milligrams per square meter, given on days 2, 4, 6, 8. And that became the gold standard for induction therapy. After induction, the GEMEMA group gave 3 cycles of combination chemotherapy, whereas the PETHEMA group, who worked closely, decided that if anthracyclines were the most important drug, then they would just use the anthracycline component, or anthraquinone, mitoxantrone. And their data are shown at the top here, and you can see this is relapse-free survival, virtually identical data showing that drugs like cytarabine, etoposide, thioguanine were not actually contributing anything to the good results in terms of relapse-free survival. And it's these data that was used to generate that risk classification, the Miguel Sands risk classification. The data here showed 90% relapse-free survival, but over time that level did not hold up, and the long-term data from these data showed a figure closer to 70% long-term disease-free survival. In Australia, we were also keen to minimize the use of chemotherapy beyond anthracycline, and so we came up with this protocol, the APL03 study, which ran from 1997 to 2002, 100 patients. We started with the same induction as AIDA, ATRA, and 4 doses of idarubicin. We used prednisone prophylaxis because we were concerned about differentiation syndrome. And then we argued that because idarubicin was the single most effective chemotherapy, we would just, for consolidation, give a second full induction. So another full 4 doses of idarubicin, continuing ATRA, and then because we were also believed strongly in the benefit of ATRA, we felt it should be used not just in induction, but gave 3 courses of ATRA consolidation. And you can see the reduction in chemotherapy we used compared to AIDA. Only just over half the total idarubicin, no cytarabine, no etoposide or thioguanine, and just ATRA and the 48 milligrams per square meter of idarubicin. Sorry, that 96 milligrams, that should be 96 milligrams per square meter of idarubicin. Our initial results were somewhat disappointing. As you can see here, this solid line shows the disease-free survival falling fairly significantly and plateauing only at about 50%, not very impressive. So we added maintenance therapy after a couple of years into the study, and the second cohort did much better. And you can see their long-term disease-free survival was around close to 80%. So at least as good as the AIDA study, maybe even a little bit better. So that was an important lesson for us. If you don't have a lot of chemotherapy in induction and consolidation, then you do seem to need maintenance therapy. So the Europeans at this time were happy with their induction, but they wanted to reduce the risk of relapse for higher risk patients. And so the phenomenon of risk-adapted consolidation came into being. And here are sequential trials from the PETHEMA group, the LPA96 study in blue, LPA99 in pink, and 2005 in green. And what's the changes that were introduced were the addition of ATRA in consolidation, as we had done in the APL03 trial, reduction in chemotherapy for the low-risk patients, and intensification of chemotherapy for the high-risk patients. And you can see that the relapse risk overall decreased successively in with those trials. When you break that down by risk group, the low-risk patients did about the same despite reducing chemotherapy. The intermediate risk groups did a little better with the addition of ATRA in consolidation, but the real benefit was seen in the high-risk patients with a progressive fall in relapse risk as ATRA was added and chemotherapy was also intensified. So on the face of it, this was a very good outcome. The problem, of course, is when you intensify chemotherapy, you bring about many other problems. And this problem became a very serious problem. Death in remission. These are patients who have already survived induction, are in full complete remission, probably cured, but with intensive consolidation chemotherapy, a certain proportion of them die in remission. And these are trials from the French, the Spanish, and the Italian groups showing that standard risk patients have a death rate in remission of around 1 to 2%, but the high risk patients with the intensive chemotherapy have a death rate between 3 and 5% in remission. And this is not acceptable. And the other problems of intensive anthracycline are summarized here: the cardiomyopathy, and of course therapy-related myelodysplasia and acute myeloid leukemia, with incidences ranging from 1 to 10% in a number of different studies. And an Australian report from the Victorian Cancer Cytogenetics Service looked at cytogenetics in patients who were in remission after receiving anthracycline intensive chemotherapy. And they found 10% of patients have clonal cytogenetic abnormalities after being treated, of which about a third developed full-blown myelodysplasia or AML. But obviously the remainder of these patients are still at risk of subsequently developing secondary myeloid malignancy. So it was the situation changed again, fortunately, in when the value of arsenic trioxide was recognized. The history of this is interesting. A herbalist in this little town in provincial China, in Lindian, was practicing traditional Chinese medicine in the 70s and started reporting very good anti-cancer benefits. So a hematologist from Harbin was sent to Lindian to investigate what is going on, why are the results so interesting. And he looked at the material that was being administered and deduced in some very elegant experiments that arsenic trioxide was the active ingredient, whereas mercuric oxide and extracts of toad, which were also present, were not particularly helpful. The Shanghai group again published the first reports in the Western literature of arsenic trioxide in the late 1900s and reported high rates of complete remission in relapsed APL, including ATRA-resistant and chemo-refractory APL. So this was clearly a very important observation. And they also then went on to show a few years later that the combination of ATRA and arsenic was superior to either drug alone, even though there had been some in vitro data which suggested they might be antagonistic. But they certainly showed at a clinical level they were synergistic. The main toxicity of arsenic trioxide is QTc prolongation, and this is something that has to be addressed very carefully when patients are treated with arsenic trioxide. And the problem with QT prolongation is it increases the risk of ventricular arrhythmias and particularly ventricular fibrillation, this torsade de pointe. And so it's very important to maintain potassium and magnesium levels in the upper part of the normal range when administering in arsenic trioxide infusions, and also to avoid other medications that prolong QTc intervals. Things like the azoles, the antifungal azoles, are a typical culprit. Arsenic trioxide has a range of other toxicities as well. It can, like ATRA, can cause a differentiation syndrome, although usually not as severely as ATRA. It's myelosuppressive. It can cause gut and cutaneous toxicity. Particularly important, this is the hepatotoxicity and peripheral neuropathy that's sometimes seen with arsenic trioxide. Concern about carcinogenicity. There's data from the Indian subcontinent that shows long-term exposure to arsenic in drinking water is carcinogenic, but so far there hasn't been any real signal that therapeutic doses of arsenic given over relatively short periods of time are a problem in terms of carcinogenicity. So based on data that arose from the MD Anderson in the early 2000s, where they combined ATRA and arsenic without chemotherapy, this study was subsequently performed by the German and Italian cooperative groups, the APL0406 study, in which they looked at combined retinoic acid and arsenic trioxide for standard risk acute promyelocytic leukemia without chemotherapy. And this was a practice-changing study, which has now become the gold standard for treatment of standard risk. These patients the study was restricted to patients with white cell count less than 10. There was also age restricted, so nobody over the age of 70. And it was also restricted to patients with a relatively good performance status. So it was a very selected subgroup of patients with acute promyelocytic leukemia. The protocol is shown here: ATRA and arsenic induction until complete remission, then 4 blocks of arsenic, 4 weeks on, 4 weeks off, arsenic given 5 days a week for 4 weeks in each of those blocks. So 80 days of arsenic here, and on average about 30 days of arsenic in induction. The ATRA is given overlapping 2 weeks on, 2 weeks off daily for the 14 days in each of those 7 ATRA blocks. The white cell count, as we know from differentiation syndrome, typically goes up in this situation, and they were allowed to use hydroxyurea only to control the white cell count. Prednisone prophylaxis was given routinely, and dexamethasone once suspected differentiation syndrome developed, clinical differentiation syndrome. This was compared against an AIDA type ATRA plus chemotherapy protocol in a randomized non-inferiority study. And the clear superiority of ATRA and arsenic is demonstrated on this data from the follow-up report in JCO. You can see all the endpoints: survival, event-free survival, disease-free survival, and cumulative incidence of relapse were all superior with ATRA and arsenic compared with ATRA chemotherapy. The clinical toxicity profile were different between the two regimens, which is a clue to how you can actually combine all three if necessary. And in fact, that is necessary for patients with high-risk disease. ATRA plus arsenic has not been shown to be a sufficiently effective regimen for high-risk disease. In Australia, we were very interested in combining arsenic with our prior APML3 protocol. So this is what we came up with APML4. We don't have the population to be able to random or to stratify by different risk groups. So we treated everybody the same, standard and high-risk patients. They got an AIDA induction, and then we added arsenic trioxide from day 9 out to day 36. So 28 days of arsenic, 36 days of ATRA, 4 doses of idarubicin, prednisone prophylaxis as before, and very importantly, aggressive hemostatic support, platelets maintained above 30, and tried to normalize prothrombin and APTT, and maintain fibrinogen with cryoprecipitate. The consolidation was chemo-free. No, just ATRA and arsenic continuously for 28 days in the first cycle, and then intermittent ATRA and arsenic blocks, 5 1-week blocks of arsenic, so another 25 days here, another 28 days of arsenic there, and 28 in the induction. So less arsenic than is used in the standard risk protocol. We decided we needed to continue with maintenance at that stage, and so we used the same maintenance, ATRA, 6-MP, and weekly methotrexate. And patients were monitored for 3 years after consolidation by reverse transcriptase quantitative PCR. We didn't randomize, we accrued 124 evaluable patients over a 5-year period. Median age 44. We accepted up to ECOG 3, so worse patients in terms of performance status. We didn't restrict the age, and so we had patients up to 78 years of age. There were 23 high risk and 101 standard risk, with a median follow-up of just over 4 years. There were 4 early deaths, and you can see that age over 70 was in fact the single most best predictor of early death rate. In contrast, the white cell count, while it was worse in patients with high white cell counts above 10, that didn't reach statistical significance. One of the main findings of our protocol was that there was absolutely no difference in relapse rate between standard risk and high risk patients. So the poor risk associated with a high white cell count with standard ATRA and chemotherapy is not seen when you incorporate arsenic into the protocol. And that translates into an equivalent cumulative incidence of relapse in a competing risks analysis. So it's about 5%, regardless of whether they have standard risk or high risk disease, as defined by the SANS risk classification. We compared our data retrospectively using with APL03 as the historical control, and we only compared it with the APL03 in which maintenance was included, so the better group of APL03. And you can see there's a significant improvement in disease-free survival, in event-free survival, and that even translates into an improved overall survival by incorporation of arsenic trioxide in induction and consolidation. In our APL03 study, we had shown, as had other groups, that with an ATRA chemotherapy protocol, FLT3 internal tandem duplications and FLT3 kinase domain mutations were important predictors of outcome. And this is overall survival showing a significant difference between patients with wild-type FLT3 versus mutated FLT3. In contrast, in the APL04 study, where with arsenic, there is absolutely no impact at all of FLT3 mutations. And there are other groups that have shown similar results, particularly Vikram Matthews' group from Bangalore in India have shown identical data that the impact of FLT3 is completely lost once you incorporate arsenic trioxide. We also did a retrospective analysis, a post hoc analysis, to see whether the benefit of arsenic in APL04 versus APL03 translated into the risk groups separately. You can see on the left, there are a total of 155 patients in the 2 trials with standard risk disease, and event-free survival, overall survival, and disease-free survival are all statistically significantly better in APL04 versus APL03. With high-risk disease, we had obviously a much smaller number of patients, There's a trend to a better event-free survival, no difference at all in overall survival, but still a significant improvement in disease-free survival in high-risk patients, APML4 versus APML3. And that's a very important finding. So our data were published in Blood and actually featured on the cover of Blood. And the follow-up longer-term data with mature outcomes were published in Lancet Haematology. And it was this data that led to the approval of arsenic trioxide in Australia for frontline use in all risk categories, both standard and high risk. So it was approved by the regulatory authority, TGA, in 2015 and funded for on the our national health scheme, the Pharmaceutical Benefits Scheme, for frontline use, regardless of risk category, in 2016. So we've had access now to frontline arsenic for quite a number of years. And as I understand it, in the UK and Europe and the USA, arsenic is still not actually approved for use in high-risk patients, only for standard risk based on the LACOCO study. So how does our data compare with ATRA chemotherapy intensification in high-risk studies? This is just high-risk data from the PETHEMA group, the European APL 2000 protocol, which restricted to age 60, and the GEMEMA study, which also restricted to age 61. You can see that this is the idarubicin equivalent, only 48 in APML4. That's 4 doses of 12 per square meter in induction, 2 to 3 times the amount of idarubicin equivalent in the AIDA-based protocols, no cytarabine, no deaths in remission compared to 3 to 5%, at a superior disease-free survival and cumulative incidence of relapse, and comparable overall survival. Remember, these patients, if they relapse, can still get access to salvage therapy with arsenic. And the US National Comprehensive Cancer Network still lists APML4 at the top of the preferred protocols for high-risk APL. For standard risk, they only recommend as a preferred protocol the APL0406 ATRA arsenic, not surprisingly. But for high-risk disease, they recommend 3 protocols: the APML4, the MD Anderson, which is effectively APL0406, but with gemtuzumab ozogamicin for high-risk patients, and the NCRI AML17, which is similar to the MD Anderson protocol with gemtuzumab ozogamicin, but uses a different arsenic schedule. And here are the comparative results. We have at least as good disease-free survival, if not better, for high-risk patients, comparable event-free survival, and comparable overall survival to the other. And these are all arsenic-based protocols. Just briefly touch on pediatric APL. I believe there's some I'm not a pediatric hematologist, and I've never treated pediatric patients. They were included in the APML4 study, but there were only 4 out of the 124 patients with who were under the age of 18. This is data from the Children's Oncology Group. Their AAML0631 protocol, which was an ATRA chemotherapy protocol in which they inserted some arsenic in consolidation, and they compared it to the historical control, an AIDA study in pediatric patients from the GEMEMA group and the pediatric GEMEMA group. And you can see standard risk and high risk patients do better with the addition of arsenic trioxide in a retrospective comparison, despite using less idarubicin and less mitoxantrone in the AAML0631. They then went on to the AAML1331, which is recently published, and compared it to their own protocol as the historical control. Over here on the left is standard risk patients, and you can see there's really not much difference between the 2 protocols. In contrast, high risk patients do much better with the newer protocol, and the newer protocol used APL0406 induction ATRA arsenic for standard risk and APML4 type induction for high risk ATRA arsenic and 4 doses of idarubicin. They gave no other chemotherapy, and they used the Lococo consolidation for all patients, standard and high risk, and no maintenance. And you can see that that approach clearly gave excellent results in pediatric patients. Just a few slides on a little side project I've been involved with recently, and that is, what about, although the white cell count is typically low at presentation, what about patients with very high-risk disease, a white cell count of over 100 at presentation? How often do you see patients like that? Well, it's hard to get information on that, but from some published data, I was able to glean that a roughly 1.5% only of all APL patients have a white cell count above 100 at presentation. There's nothing published on their characteristics, outcomes, or how they should be treated. So I was able to collect 37 patients from 5 countries who had been accrued over over 20-year period, from Australia, the UK, Canada, USA, and Denmark. The median white cell count was 124 at presentation, ranging from just under 100 to nearly 300 by 10 to the 9 per liter. And we stratified them into 2 groups, whether they had presented before or after 2012, in other words, 10 years before or after I did the analysis. And I used that as a landmark to separate people into the early era before 2012 and the late era after 2012, who were more likely to have better hemostatic support, better support in terms of platelet and blood product support and treatment of differentiation syndrome better, because of the world was increasingly aware of all those problems. This is when you overall survival stratified by the era of presentation, and that makes sense. You can see the main difference is this huge difference in early death related to probably inadequate blood product support in the early era patients. When you stratify by whether or not they receive arsenic or not, you see virtually the same pattern of curves. And that's because the use of arsenic is tightly correlated with a late era presentation, because most countries have not had access to arsenic trioxide for a very long time. Certainly very few patients more than 10 years ago were getting arsenic routinely. So I thought, well, what we're seeing in the non-arsenic curve, as well as the early deaths, we're seeing some later deaths as well. And these later deaths were relapsed APL, and therapy-related myelodysplasia, acute myeloid leukemia. And so my feeling is that these later deaths are a true reflection of no arsenic, because these people are at higher risk of relapse and at higher risk of secondary malignancy, because they have more intensive chemotherapy in induction than these and consolidation than the arsenic treated patients. So I think that while this data is very soft and very retrospective and limited in quality, it does imply that even for very high risk patients, white cell counts above 100, it's still helpful to have arsenic in the protocol somehow. And when you compare the survival of these late era patients with extreme hyperleukocytosis, they actually did pretty well. And virtually all of these patients had arsenic as well as being good blood product support. 91% overall survival, compared to data from the other arsenic-based protocols for high-risk patients with white cell counts above 10, so in the high 80s. And finally, just finish up on a little bit on oral arsenic. Arsenic trioxide, as you know, is intravenous, given by 2-hour infusions over months. So obviously this is a problem for patients and a problem for hospital resources. An oral formulation would be a wonderful improvement. It simplifies treatment, reduces resources. And so what are the possibilities? Well, in China, there is Realgar Indigo formulation. There's a Hong Kong liquid oral formulation. There's an oral capsule formulation being developed by Febra in collaboration with the Australian Leukemia Lymphoma Group. And in the US, Syros has also an oral formulation. This is data from Realgar Indigo Naturalis formula, the Chinese oral arsenic. And this is a randomized study of oral versus intravenous arsenic trioxide in standard risk patients. It replicates the Lococo APL0406 study, but just used intravenous versus oral arsenic. And you can see, and the arsenic is not arsenic trioxide in this formulation, it's tetra-arsenic tetrasulfide with some other compounds as well, which are said to have anti-leukemic activity, although exactly how good that activity is, I'm not sure. But as you can see, this is a non-inferiority study, and there was, in fact, comparable data with both oral and intravenous arsenic. In Australia, we've just completed the APL05 trial, which is oral arsenic in previously untreated patients with acute promyelocytic leukemia, a phase 1 pharmacokinetic study. The outline is shown here. To get into the study, you had to already be in complete remission with an arsenic-based protocol, either induction with APL0406 ATRA arsenic or induction with APML4 if you had high-risk disease. Once you're in remission, you could then go on the study and receive a typical Lococo consolidation, 4 blocks of arsenic combined with ATRA. And we, after a pilot study, trying to make sure we had the right dose, we then randomized to just the order in which we studied oral versus intravenous arsenic. So in week 1 of each of the 4 blocks, we did pharmacokinetic sampling on days 1 and 4, and whether that was oral or intravenous arsenic, and we just randomized the order in which we did that, and we repeated it to look for intra-patient reproducibility. And then we examined the pharmacology, the pharmacokinetic parameters using the arsenic levels that were collected over the 24 hours on day 1 and 24 hours on day 4 in that first week of each cycle, and calculated the Cmax and the AUCs. And then all the data were aggregated, and this is one summary slide to show you, and this data was presented at EHA recently, shows you the average ratio of the oral to the intravenous formulation for each of the parameters, the AUC 0 to 24 in whole blood, the AUC in plasma, Cmax in whole blood, and Cmax in plasma. And if these formulations are equivalent, the ratio should be close to 1. And as you can see, the ratio is very close to 1. And more importantly, the 90% confidence intervals around that average figure are well within what's defined as bioequivalence limits, 0.8 to 1.25, as defined by the European Medicines Agency and the FDA. So we believe we have shown bioequivalence of the oral formulation against intravenous arsenic trioxide. And I think I'll leave it there. In summary, I think you can see there have been dramatic improvements in outcome due to ATRA and arsenic, and very importantly, optimal supportive care. Almost all patients can be cured now with frontline therapy, but early death still remains the major cause of failure, particularly outside a clinical trial. And the current aim is now to improve treatment by improving the quality of life without loss of efficacy by transitioning to an oral-based arsenic regimen. And I'd just like to acknowledge lots of people, there's too many to list by name, but all the people involved in the Australian Leukemia and Lymphoma Group studies, my own laboratory, which did molecular centralized monitoring for the APML3, 4, and 5 trials for the whole country. Local, national, and international colleagues, particularly in the high-risk extreme hyperleukocytosis study, and of course the patients who've consented to being part of our trial. And I'll leave it there. Thank you very much.